call meeting to order and Sharon, you could just take roll from what you see, right?
Yeah.
Okay. So approval of the minutes,
I'm waiting for it to start recording, it's going slow.
No technical issues.
Sound.
donut.
Fix this page.
All right,
Everyone can hear us? Alright.
all right, so we'll call the meeting to order. Sharon's taking roll, but as you can see, the approval of the agenda.
I recommend we approve the agenda.
Lisa, you second that?
Yes, I do. I second.
Thank you. Is anybody here from the public that would like to speak? See nobody online or in the room from the public. Go for the approval of the minutes from November 13th, to 2023. Anybody got a chance to read them?
I make a motion to approve.
Shelley makes a motion to approve it. Lisa,
I second.
thank you. Okay, new business. Go ahead and turn this over to Gayla for our presentation of our annual plan.
Thank you, Mr. President. I am going to be presenting the Bartlett Hospital Patient Safety and Quality Improvement Plan for your review. This is a requirement by CMS, Conditions of Participation and Joint Commission, that the hospital has a patient safety and quality plan that is approved by the board that gives the hospital the authority to have a quality and patient safety plan. You had the opportunity for the last week to review the plan, so I'm just going to go over a few highlights in the plan. The executive summary kind of went over what the plan hoped to accomplish. It talks about the structure and the purpose of the plan. We looked at the plan. We basically take it from a IOM vision of the plan through it, and what I did is I have based our internal structure as looking at our on page 7. I just want to give a highlight to our internal structures of our coffee meeting. So this is how the board internally gets our patient in our quality assurance and process improvement data. Because this is a important factor for you to get our process improvement, quality assurance data up through the board level. So this starts at department levels and will come up to the board through the board quality meetings, and then our patient safety committee. Our patient safety committee is comprised of all of our critical areas in any departments that have direct contact with patients. And then our department and services, any department or service is responsible for doing process improvement at a department level in the hospital. And then other things that I wanted to give you just a highlight on, I did give examples out at that I have larger copies here if you want to see. I'm working on a new board quality patient safety dashboard that will be coming out quarterly at the board quality meetings that will have a little more in-depth metrics in a more dashboard form. So if you want to take a sample of it, it's still in draft form to take a look at. This is not approved through the plan, but it's just a sampling that will be coming out for you on a quarterly basis to give you a little more breadth and scope of the things that the hospital is measuring. And what we did on our dashboard is divided up in some of the categories that are looking at safe care, value, engagement related to staff and physician engagement, and then some of our clinical care areas. And then starting on page 10 to page 11, I have a lot of our metrics that we are measuring out. Some of those you will also see in our infection control plan that Charlie will be presenting in her plan. And then some of them are also measures that are looked at in our value-based purchasing plan and other plans that you might also see with Jeanette giving some information on our case management and plan later on, and also some of the things that Mark reports on through his environmental care plan. And then the end of the plan, I did put in some of our methodology for what we do for PI, and then I added some references at the end of the plan this year. So I'll take any questions from the committee members if you have it.
Lisa? Chuck?
To the chair. First off, I just want to say a big thank you to you. This together, I think this is impressive. So thank you for doing that. And then one of my questions was, I think my numbering may be different than yours, but for the safety plan priority objectives, can you just give a brief description of how you chose those? I know some of them are related to the CMS and stuff.
Okay,
But how you, yeah, how you chose them for like the hospital.
So what we do on our objectives, so our multi-year objectives are looking at things what matters across the hospitalization. So when we look at accreditation and certification, this is very important to the hospital for us. For CMS certification, we want to stay accredited, certified, of course, because Medicare, Medicaid billing is important to the hospital. So that's an easy one to choose. When we look at other things like developing a patient family engagement program, again, it's a CMS requirement, but it's also very important because if you have good engagement by your patients and your families, you're going to have better outcomes. They're going to be more receptive to their care, hopefully stay out of the hospital. It's going to reduce readmissions. Other things that we're looking at is improving our star ratings. Of course, if we're hopefully eventually getting to be a 5-star rated hospital, it's going to help our reputation, hopefully improve more people wanting to come get services at Bartlett. Other things that I know Jeanette will be able to speak highly about is things like our CDI, so clinical documentation integrity is a way that we are going to improve how we document. And ultimately that will help with our reimbursements, because if we do the best documentation through our electronic medical records, we can hopefully capture that in our coding. Again, it's going to represent the best care that we're getting for our patients, and it's going to help transitions of care, but it's also going to help our bottom line of the hospital. So that's how I chose our multi-year objectives. And then our other objectives that I'm looking at, of course, infection rates, very important. We want to make sure that we're doing the best care for patients. Improving sepsis, falls, these are all things, these are nursing indicators that we're doing the best care for our patients. And then, of course, engagement. If we can keep our staff and our physicians engaged, we're going to get the best staff caring, doing excellent outcomes for our patients.
Lisa, do you have any questions?
No, I had some earlier, but they were answered, so I'm good.
Anything?
No, I think that was, I talked to Gail beforehand.
So,
So did I.
oh, great. Al, do you have anything?
No, okay.
Move on. That it?
That is it, and then if we scroll down to, I just have one other beyond this document. For the 2023 quality metrics, just to go over what we had for last year. We had quality goals to complete our survey on patient safety. That is partially met. We did complete the survey in December. The one thing that we have not done yet, which the board quality will receive the full report in March. So I marked this as partially met since we have not reported out to the board yet. We'll receive that full report out in the March board meeting. But we did complete the survey. The physician engagement survey, that was completed with Dr. Rosenfeld, and he did give strategies back to our CEO on recommendations to help improve physician engagement. So that goal was met. And then implement the online peer review process and track through credentials stream. That was not met. We are still working on that, and we are actually rolled that into our 2024 goals that we're working on. And that's a collaborative process through our med staff office. So we hopefully will have that done by the end of 2024. And then sepsis. We did not meet our national average this year. They rated it at 56%. We did not meet that. We ended up at 37% for the hospital. It's a challenging measure to meet. Some of the things that I think we are continuing to meet this because sepsis is, a significant concern for outcomes for patients, and we need to work on this. Every hospital does. But things that are coming that I think are going to help us achieve better outcomes are the integration with the EMR for the emergency room is now on the same EMR as the hospital because we had some transition issues between ER and CCU. And the other thing is that it's now one of the metrics that the emergency room physicians are tracking on their scorecards, their OPP scorecards that they're getting. So they added that measure, so they're tracking it individually. They agreed to that. So now that they're tracking how well they're doing on sepsis measures individually and as a group, I think that is going to help us work to meeting hopefully the national average in 2024. So, and the other thing we are doing is we've joined with our AHA's group. We have a sepsis collaboration that we're starting the end of January for the spring that we are involved in. So we're having a new focus on sepsis. That is an interprofessional team. So hopefully that one will change this year. Because we do have some people that got very sick with sepsis last year. And that's it.
Thank you. Seeing no questions, I'll move over to you.
I'm sorry. Yeah, and I'm sorry to ask this because I've asked this before and you've answered before, but could you remind me what the sepsis measure is?
And I might defer to Deb Kelch, if that's okay.
Hi, can you guys hear me?
Yeah, how are you?
I'm fine, thank you. So, how, like, is there a specific piece of the sepsis measure or just in general?
I'm just looking here, it's saying 56%. I'm thinking, what is the percent of what? I don't know what it.
So sepsis is a process measure. So it's tracking exactly, how we treat patients that come in and that meet specific criteria related to sepsis, and it kind of tracks how we treat them against the specifications that CMS has put out there and how they want us to take care of those patients. So it doesn't mean that every patient that comes into Bartlett and that has a sepsis diagnosis is in this measure. It's a defined population, a little bit too lengthy to get into here. Anyway, it's so the patients that do meet the criteria and end up in that population, excuse me, there are, well, I counted, the last time I counted was a couple of years ago, but there's been a few more things added, but there were 42 specific data elements that we have to actually check a box on in order to pass this measure per patient. So what that means is we have a lot of, yeses that we need to check on that. And the care of every patient is so different. You can't just kind of slap one treatment plan onto everyone that has a similar diagnosis. So, the doctor has to treat the patient according to what they're seeing in front of them. So even though CMS has laid out all these guidelines saying, we need you to provide, X amount of fluids in the first 3 hours of care, or an antibiotic in the first 3 hours of care. There's specific things like that they want us to do, and it's not always the appropriate thing to do at the time, right? Because the physician has to use their judgment in care for a patient. So, our staff does try to follow it as much as possible, but it's just not always possible. So I don't ever see us getting anywhere close to 100% on the measure, but it is considered best practice, to follow it, the guidelines as much as possible. And we're just, as Gail mentioned, kind of looking at that again and just kind of getting word out there, updating staff on the latest guidelines and everything. So as far as defining the sepsis measure, it's kind of difficult. I can always send you the full specification for you to kind of look at and maybe understand a little bit better. But
Well, I didn't want all the details. So if I'm understanding right, if I go in the emergency room and I'm dripping blood on the floor and I have a big laceration, they're just going to sew me up. That don't have anything to do with the measure. But if I had a recent surgery and I come in, I've got a fever, I seem shocky, then there's a bunch of things that have to be checked off.
Yeah.
Is that?
That's exactly right. If the doctor feels like that you're going into, that your body is going into sepsis, where you're heading towards organ failure, that kind of thing. Yes, absolutely. As soon as they put that severe sepsis diagnosis, they're going to start, moving towards treating you for sepsis for the measure guidelines.
Okay, thank you. Sorry for that.
Thank you. All right. Thank you. So we'll move on to Charlie.
Thank you, Mr. President. My name is Charlie Goodman. I'm an infection preventionist. I've been in this role since 2017. So I have before you the draft for 2024. And it included, I'll go over it briefly, but we won't have to dwell on the documents. The risk assessment, how I define what risks are ahead of the hospital and what we should focus on, as well as looking at how well did we do with our infection control goals last year, as well as epidemiology, surveillance, and other things that happened that I also. So our objectives have stayed the same. Early identification of infections, timely implementation of interventions when infections or risks are identified, analysis of organizational and individual practices that impact transmission of infection. There's a lot there that guides my job as well as my surveillance, looking at what happens and then improvement activity. The purpose hasn't really changed, but this is just to also guide who is on the infection control committee, how we meet, what we do in terms of like timely interventions. Say there's an outbreak, what are my powers to gather the team together or talk to the medical director? None of that has substantially changed in the last year. Every year, looking at page 8, I do a community assessment. What's changed in Juneau? What are our industries? I do a community assessment of our hospital. What has changed within our workplace, the working well, the employees? What has changed within the patient population? Definitely what has changed within Bartlett this year is we now oversee and have included wildflower courts. So that is also a separate risk assessment and a separate infection control plan. But the way that we are working together is that their issues come to the infection control committee of Bartlett.
Question on that? So do you develop that plan or they develop their own?
We're currently, I am acting as a consultant to Wildflower Court. And Cynthia Gordon has the 20 hours. So there's a part-time infection preventionist. So over the summer, she got trained and I worked really closely with her and we did the risk assessment over a couple months and developed a plan by fall of 2023. And then right now, we're just gonna take what she's learned in her surveillance and do a new one for 2024 for them. So yeah, we're just kind of like walking slow with Wildflower Court, but doing the same stuff. Yeah.
So Charlie, do they have a plan right now?
We have the 2023 plan. Yeah. So I haven't really set a timeline of when things are due over there, since it's not really my job, but we're working with them.
They will move to approve it.
That's what they're asking. Oh, yeah. Yeah, they're still not sure how.
Yeah, because I know Kim was here last meeting,
yeah.
and she's not here today, so
Okay.
we're not presenting.
Not yet.
This is kind of a picky editorial matter, but I see that most of the conjunctions in there are and/or. And by doing that, the logic isn't always clear. I mean, for example, if you say a patient can be discharged with voided urine and eaten, that's one thing. If you say we discharge, if the patient's voided or eaten, that's another thing.
Mhm.
Two completely, the logic is completely different. But if you say it can be discharged if it's eaten and or voided, then that's not clear what that means. So there's some people who were given responsibility and it says if it's this person and or the other person. So and means one thing and or would mean a different thing. And I just see consistently, there just seems to be that sort of hybrid conjunction. So I think the logic would be clear if you went and told the reader exactly what logic you meant.
Good catch. Never ever since then.
How were you at?
It's in here in a number of places. For example, on page 482.2, the chair of the IPC committee and or the infection preventionist may do these things or have responsibility, but it's in a number of different places. I think if you look at the line above it, there's also and/or some logic of something.
So maybe we can go offline and you can maybe talk with Charlie or Gail.
Well, I think I made my point.
You want clear direction.
So these minor corrections that we're just want to make sure that we're going to be able to approve this plan with these minor corrections. With these minor clerical corrections, correct?
Yeah, no.
I just want to make sure that the committee is on board with that too, right, Lisa? You too? Thank you. Thank you.
Well, briefly back to the community assessment, substantially, nothing has changed with our population. Or the age or the risks of the population. Even with the addition of Wildflower Court, it's just another service and people look at a different subset. What has changed significantly, and I've highlighted the red things, the tourism and what brings people to Juneau definitely impacts what diseases come into Juneau, how long they stay, what workers are here. And we significantly, like in the past years, there's only been limited data on tells me how many people come into Juneau, but this last year we had a significant amount of people. Not just, I think I had said 30% increase. So we have 1.6 million visitors. So I'm not sure, I haven't done the math on that, but on a daily basis, like how many more people is that? So I definitely wanted to say something to that point. So I chose significantly. Cruise ships, we do have a changing world with climate change. I didn't have to put that in there, but just new and novel diseases are coming to Juneau, so we have to be aware of that. Also of significance is 2022, the Alaska Department of Health had noticed a significant increase in tuberculosis, 64%. Juneau, we are a huge state, so that still didn't change our risk assessments. We don't see a lot of tuberculosis, even with the tourists and the crew members that come in. Our rate has stayed the same, but Alaska has changed. And then that's about it. For our population, we definitely have some fluctuations, especially during the pandemic. And these last couple of years trying to not have so many employees, but we do have 800 employees total. 614 are those are full and part-time, so those are our main staff. So just wanted to highlight that change as well. All right, moving into the goals. And so I'll quickly tell you how I choose these. I do a risk assessment. It looks at different factors: hospital-acquired infections, infectious patients, employee transmission, water, and hazardous materials. I think there's one other. So you look at how likely is this to happen? What do you know about it? What is our internal policy? And how likely are we to respond, readiness to respond, and then how have we responded? So all of that goes into choosing 1, 2, or 3. It spits out a probability for you. So again, our top priorities based on that risk assessment are new and novel diseases, infectious patients, and transmission in the hospital. And so that's how it kind of percolates into what do we do for infection control? And first primarily is to first do no harm, don't spread disease. So hand hygiene and environmental cleanliness is at the top of that list. So goal number 1 is improve compliance with CDC guided hand hygiene. Our key risk, I wanted to kind of highlight that, is infectious patients, medical tourism, and novel pathogens. Strategies to do that this year: continue to engage staff through education, training, and data collection. And we did a little bit of a lot of work over the last year, and made some significant improvements in how we're going to get more people to collect data, because that's my main struggle. Is if I'm the only one collecting data on hand hygiene, it's significantly biased. I can't collect enough data to have something there. So we've trained, we've got some people engaged, and now it's just keeping them engaged and keeping those observers collecting data for me. So to my goals here, I want to increase and keep above 88%. In 2023, we were 79.8%. And again, I cringe to say that this appears low, but it's also because I don't have the observers out there gathering the data for me. Press Ganey is something I go to as like, how well are we doing on a national basis, and how well do the patients see us? Because that's the other thing I'm not gathering. It's like the nurse comes in the room, washes their hands, gets gloves, good technique, right? What does the patient see? And so they are quizzed or polled, sorry, on how well we do. And we're doing really good in their eyes, 83.6%. Some significant achievements this year is for over, I don't want to say how many years, but we've wanted touchless dispensers. So as you can see on the walls, this new product, Medline, has been in the works since January 2023. And those just got up on the walls in November. So I'm super proud that we have touchless, and pleases most people with the amount it dispenses and all of the unique feedback I get. So anyways, that's really good to have touchless, great product available that has a good supply. Other thing we did this year is we started some competition between units and between people to get more of that observational data and to have people engaged as to why I'm asking them to collect data. And we've got a hand hygiene cup. So I've got a gold-plated hand sanitizer dispenser. So for the unit that gathers the most data, or could beat me in gathering data, I haven't decided what to really throw out there to tease them, but they'll get to display this beautiful gold trophy on their units. And if the whole hospital wins, maybe it goes in the lobby. I don't know. But yeah. So that's hand hygiene. We did fairly well with surgical site infections. These are something that really impacts people's quality of life, and coming back to the hospital sucks. I mean, it's a lot of money and it's a lot of an investment to go get surgery. And so this is something I'm really wanting to strive for with the work of surgeons and surgical services. So we've been wanting to engage and get this done, and we have some implementation of this enhanced recovery after surgery. But it does take a lot of complex teamwork there. So I'm gonna choose one of those things to add to our interventions on how to reduce surgical site infections and work with the team. And the other strategy I'm really excited about is, improving that communication of infections I find and review with the caregivers that are in the room with the patient. So that's something that we did do quite well last year. 0.4 per 100 procedures was our infection rate, and our goal is 0.3. So I am very satisfied with that, and we did not have any total joint infections, which is also significant for my time here and what I surveil. We did have a couple colon surgeries, and why I mention that is the Infection Control Committee defines what they want to surveil and keep track of. So we could spread that data broader to find out where our weak points are, not just what CDC wants to hear about. And they want to hear about colon surgeries, knees and hips, and hysterectomies. They don't want to hear about the other things. So we defined, okay, we got an infection, this person suffered. What could we do better? So anyways, what we reported to CMS and CDC and hospital.gov was 2 infections last year. And we've had 7 total infections out of 1,700 procedures here at Bartlett for 2023. All right. And then infection prevention goal number 3, again, respiratory viruses are just so hard to stop when you work closely with patients. And we had significant, in my 5 years doing this, I learned something new about what matters to workers about vaccinations. So getting people their flu shot, getting people their COVID shots, all these things matter. Wearing masks matter, but I found a breakthrough in doing a mobile cart more often, so meeting people where they're at. And we had a lot of compliance and a lot of feedback that was a great thing. So last couple of years, interestingly, we struggled to get to our goal of 85% flu vaccination during the pandemic. And this year, we did meet that on time at 85% November 1st and 87% by 87 by 11/1, 90% by 11/15. So we do pass our goal, which is very. And
Oh, yeah. Do you think that was related to the mobile?
yeah.
Nice job.
Well, I mean,
Yeah.
definitely, yeah, and making sure that things are on Fridays and that we have adequate vaccines at night shift. Some things really just, I would get more people as I was rolling by and be like, hey, you need it? And they're just like, oh, you got me. Yeah, sure, it caught them off guard, so definitely that was. And to get it when I wanted it done. Yeah, we spent 6 weeks doing this, and I didn't want to spend another 6 weeks tracking people down. Strong work. And then one thing, I haven't gotten the final approval from Infection Control Committee on this, but one thing I'm working on in October, the state contacted me, had a patient with Candida auris, which is a resistant fungus that lives on the skin, it's in wounds. With people that are in the hospital a lot, it can be very persistent and hard to treat on the patient and in the environment. So with that knowledge, we had a risk assessment done with the state to take a look at our facility and how well we're doing hand hygiene and cleaning and looking at risk. And we learned a lot through that visit. And I've been wanting to do this with environmental services, is looking at tagging rooms with some blow germ, seeing how well we wipe things down. It's an objective measure. So I'm working on that. It's kind of related to hand hygiene, but environmental hygiene. So that's another project I'm working on that isn't specifically outlined in a goal. Okay. That's not our plan. Comment?
Any questions? Any questions? Charlie?
Well, of course, I'm gonna have, I don't think. So one of my questions is, do you have the resources and tools to continue this?
Good question. Yes. That's why there's not 12 goals on here. But yeah. With working with education and the directors and my own energy and drive to be extroverted and get people out there. I think we have. Yeah, because a lot of this is collaboration with units, surgical team and EVS.
To the chair.
Yes.
Yeah, a lot of this really takes CVS, you know, Charlie working with the teams, with the clinical teams, and I can't say enough of having a really full, strong EVS team and her working with them is really what keeps our infection rates down in the hospital. Because our environment is really a big part of it.
Thank you.
Thank you, Charlie. Maybe go ski him out or something. All right, next up, looks like, Mark.
Good afternoon. I have 6 environmental care management plans that are required to be reviewed annually and approved by the board of directors. And I'll go through each one of them. We did full rewrites of many of these plans just a few years back. So as the regulatory requirements are pretty static, you're going to hear a lot of no proposed changes for 2024. The first one is life safety management and change for 2024. We have performance improvement measures that we set last year. So the performance measures for 2023 and their outcomes wanted to provide annual hands-on fire extinguisher training to staff to get it out to about 90% of staff. As we worked through the year, we realized that we were capturing a lot of staff and training them hands-on with fire extinguishers, but we weren't documenting. So we're going to go back in 2024 and make sure we're documenting as we go along, and we've included hands-on fire extinguisher training in the documentations. The fire response plan wanted to update the department-specific plans throughout the course of the year, and we made it about 90% of the way through doing that. Just a few little changes we noticed right at the end of the year, just pertaining to how fire extinguishers were used within the facility. So we're going to change a few of those things up. We'll get that goal met by the end of the year, or excuse me, by the end of the month, actually. So performance improvement measure number 3 there was to complete a new evacuation plan. And the committee just didn't have the opportunity to start working on that, and they moved that priority to 2024, as well as developing a questionnaire for the staff and using the Elias to get that out to measure their understanding of the life safety plan. They also didn't get that out for this year. They're going to move it to 2024. And it's not that we're not gathering information, because we're going out and we're interviewing staff to see what their understanding is. We just wanted to move that to an electronic format. And on the next page are the new performance measures for 2024 and goals. And I'm not going to go through each and every one of them. They're in your packets. They're here. And I just like a couple of highlights for the life safety committee, things that they had accomplished was a surgical services fire drill specific within the department, engaging physicians. So it was a success. We've only managed to pull it off a couple of years in a row now. So I think we're learning better how to manage potential fire in the OR and making it safe for everybody. And then another one is the long drawn out fire drill project. It's been going on for at least a couple of years, right, Kenny? At least a couple. So, and we are down to literally 5 small items we just have to complete, and it's really just delivery of some keys for some delayed egress devices. So we are this close to finding the route now.
Yeah, I see an island on the property here, so that's great.
Yeah, it's close. That's an accomplishment for me.
Can I just ask a real quick question, and maybe this isn't a time for this, but with this plan, the fire safety plan, does this also include the Clark too? As well?
So this particular one does not include wildflower court. I'm working with Zach and the team over there to really define what their standards are. They're being CMS survey versus joint commission. I mean, joint commission is just slightly different in what they request for documentation. So we're cross-referencing the two to just make sure we're on board. They've been CMS for.
So one of the questions I have is I see that the percent of training went from 90 to 75% for the fire extinguisher training.
Right.
And is there a standard out there, or how did you choose that?
No, I think they started looking at it more realistically and how many people they could capture as they started doing it through 23. And so just reestablish that goal. More realistic.
And is there an industry standard?
There is.
There is.
And then, for the evacuation plan, do you guys have a timeline for that?
So no, we do have an evacuation plan that's in place. It's about this thick and it's fairly complicated. So really what they're trying to do is they're trying to pare that down, make it a manageable, more usable plan. So it's no timeline, they're just know it needs to be tightened up.
Okay, and I always ask about timelines because I think timelines help us in finishing projects sometimes.
Yes.
And maybe realistically, your timeline is 2025, I don't know, but. So it's it.
Thank you.
Thank you, and great work, getting the physicians involved in training, that takes a lot. So strong work on that.
Hey, Mark, just one thing, the evacuation plan, each department has their own plan available for them right then and there, so it's not like it's just this huge book, you know, each department knows where to go when we need to evacuate.
Right, so we have it online. We don't have the evacuation plans in each department. Those that
Okay,
they don't know. So it's online and we have with the command center, the big binder that. We used to have binders in every department. It was decided by the emergency management committee to pull them back because it was really too hard to try and keep all those binders updated throughout the facility and remain consistent. We did inevitably find one here. So decided to pull them back. Centralized.
And through the chair, this is one thing I'm talking about with emergency management is some of the drills that we're planning on doing this year is doing level evacuation, whether it's horizontal or vertical for the departments. And that is one of their goals that they're looking at in conjunction with this for this year.
Lisa had a question.
Hi, Mark. This is excellent work. I do have a question for you though. It seems like it's always been challenging to do the fire extinguisher training. Have you identified what the barriers are so that, you know, when you start doing this, that you'll have more participation?
So barriers are really getting enough opportunities for staff. Charlie's concept of getting out there where the people are working is probably something that we should really start working towards. I think she's on to something there, and I think that if the group works that direction, it'll help. So barriers are really available.
Okay, thank you.
just want to agree with everybody, great work, Mark. Thank you.
Well,
That was one.
I'll save my other question till the end.
So the next management plan is a safety management plan. Go and proposed changes for 2024. So we'll move on to the evaluation. So a performance measure number one for the safety committee was to reduce the incidence of sharps exposure to at or below the national average. Don't look at the numbers there. The rates and how they were calculated and filled in were, it was wrong.
Your glasses off.
Yes. I was looking over it. So essentially, the beds we have in the facility, we need less than 17.1 sharps exposures for the calendar year. And so in 22, we had 11. They've done some initiatives around training and identifying high-risk areas and high-risk products, and have reduced that down to 4. So, it's great work for the group. So if we can keep going at that, we are well below the national average. So that's great. And then OSHA recordable injuries to staff, we wanted to decrease that by 30%. And we went to a goal of 10, and we had 8 reportable injuries. I think we had one sneak in right at and took us up to. Yeah. But so that's still below our goal, so that was a success. We want to do a risk assessment in one high-risk area, and so we actually opted for the Crisis Stabilization Center, the 3rd floor, and went through that and identified all kinds of fun stuff that would have been caught after the fact. Some of them were actually changes to the contractor that we implemented, and some were with our staff. So that was a success in pre-catching some of the issues and concerns. Look at your risk assessment in MA2. We want to do that every year and work our way through that. And so that was completed for spring. Workplace violence prevention and implement a tracking system for that. The committee worked through that, and the goal was 100%, didn't quite finish. Back to 75%, and we'll continue that into 2020. And if I'm not mistaken, it's really the tracking. That was missed. Okay, the next one, finalize and implement new patient visitor policy, weapons, drugs, so on and so forth. That one was written, draft was, and got hung up in CBK legal in the free carry state. Challenges with that, so we will continue to push that into 2024, and we'll maintain our plan of putting signs up and telling people that we're weapons free.
Okay, so people are allowed to carry weapons in the state concealed, right? In certain places, and there's certain places they can't. But I thought that the proprietor of any entity can make something weapons free.
We're owned and operated by the city of Burlington.
Correct.
And so CBJ legal says we can't prevent people from carrying concealed weapons.
I wouldn't say they haven't said that we can't, they just haven't approved us moving forward with saying. So essentially the same thing, we said we can't.
We can't. We've been fighting this for 2 years.
So they can change it, but they can't change it.
We cannot, tell people they cannot carry their weapon at market. That would be against their rights.
They can't school.
It's interesting, right?
Yes, it's very interesting.
Hopefully, if we keep hitting them enough times that somebody will see some logic. If it's a government facility, then the courthouse doesn't offer us.
Exactly.
Okay,
We'll
moving
talk-
on.
I know you've done nothing about this. I'm sorry.
Last two items on there were monthly reporting of employee safety issues and concerns to the board. And I believe that happened one quarter, and then there's been some back and forth about whose responsibility that might be with the safety officer. So I know that there are multiple people working on defining who has that. And then adding dashboards for needle sticks and workplace violence to the daily safety huddle. It was decided that dashboards without appropriate safety huddle was more of a verbal. And performance improvement project, Safe Sharp Solution, gas, there was quite a few initiatives there and it just didn't get to the performance improvement project, Safe Sharp Solutions. So they'll be moving that to 2020. And listed there are the 2024 performance improvement measures for safety. A couple things that went well. We've already talked a little bit about them. Sharp's injury reduction and reportable injuries reduction. So, question on safety.
Actually, my question mark is do you have the tools and resources you need?
Yes, most of this work happens through committees. So we solicit frontline staff, get them on the committees, have supervisors that are working on the committees as well. So it's really an organization. If I were to say there was one place that we was really lacking safety, sure that is a good plan.
Thank you for all your hard work.
I don't want to belabor this, but I'm reading from the Alaska State Troopers summary of the statutes. And it says exactly this: the owners or management of facilities, including such places as hospitals, universities, gymnasiums, or private property, may restrict or deny concealed carry purposes. So I've gone right back to the statute.
So we're not the owner, CBJ is the owner. So we have to get CBJ to agree with us.
Owners or management of facilities. I think we're the management facility. Or even if we're not, then
Again, I think that we should have legal has that, you know, it's all legal's interpretation. I don't disagree with you.
Yes.
We all are in agreement.
Absolutely.
We are absolutely 100% agree with you.
yeah, okay, I don't want to belabor this, but I think we should make sure that we're getting a correct interpretation of the statute. Thank you.
So I just want to say one thing to Mark is I remember when Jaco was here, and one of the things that they were impressed with that they ask a lot of people around our campus, what's your role in safety? So person that's you know, EES or someone like that. And Gail's the one that actually told us in the meeting, every one of our employees knew what their role was. None of them said, well, I don't know, I have nothing to do with safety. So that's really good leadership. So thank you for that too.
It takes a village, right? So we have so many different ways we're hitting staff with that. Autumn was just priceless in her role of getting that knowledge out of staff.
Lisa, do you have any questions?
Campus security. So, whoa, red lights, holy cow, right? So the content of the security management plan did not change, even though it sure looks like it did. It was just rewritten and removed, things were moved around in the document, rearranged some. This is one of the management plans that did not get back. So this is Derek, the security supervisor's front at realigning things with the way he felt that they should flow. So no real content change, just a lot of movement. On to evaluation. Performance measures for 2023, increased core competency training for security staff. And advanced training and de-escalation. So as we rolled through COVID and we ran through the aftermath, if you will. Some of the specialty training for our security officers just fell off. We bring people from South to train. So people just want to travel to train. We finally got that back on board and we got our current staff trained up to with those specialty training. And it's a job well done, and we'll continue down into 2024. Develop a written strategy for testing of the duress portion of the SARA system. There was a written strategy it was written, and I keep hanging it up. I keep kicking it back to Derek, saying, what about this? Let's think about that. So I'm the one that's hung it up, so we're not quite complete as the year has gone through. So, well, he's really close. We'll have this.
What is the SARA system?
You see the smile on my face, I think that was, so SARA stands for Situational Awareness Response System. And it's a wireless network throughout the facility to where we can actually write different things onto it, boiler alarms, in this case, duress pumps, staff. We will finish that in 2024, reinstitution of what's called swarms. And then swarms is where we go out and gather data from the departments about security management. They didn't do a whole lot of that in 22, and started doing that again in 23, and we got most of the way through the departments. So that's a success. They will continue into 2024, and I'm going to provide a few other tools as well. We've recently been approved, thank you, for a electronic tracking system. And then updated security management plan. You saw the red lines. So and then new performance measures for 2024. Continue to discuss SARA system, swarms, getting them into a written process, and new systems. And working towards a written strategy for emergency radio maintenance and distribution, keeping those dang batteries charged up so we're ready for us when we need them. Right? A couple of things that went well. Security management is the training, getting those folks to train our staff. Questions about security management? Okay, next one's utilities management. These are, of course, ventilation systems and power and emergency distribution and all those different behind the scenes components, and no proposed changes for moving into 24. Performance measures. There they are. So we've been working, it's been a multi-year project to revamp the inventory management system for all the parts and pieces to maintain all the buildings on campus. We've gone through it. Wonderful system now. They're all labeled, they're all barcoded. We're entering them into the system now. We're just entering basically price data for them. And so it will take us most of the board to get that up. I'm anticipating that eventually we're going to be asked to, instead of just completing a work order for a specific department, we're going to be asked to complete the hours it took, parts and costs associated. So this is part of preparing for. We're gonna do it for Wildflower Court for starters, right? So we have to do this. Then scanning of historical blueprints, we wanted to get 90% of the way through that last year. We have a room full of historic blueprints, and we have a large format scan for getting into electronic format. And we've had some issues with the scanner over the course of the year, so we only got 50% of the way. We have those issues sorted out. Hopefully we'll finish that in 2024. Then relabeling and circuit breaker panels. Any facility that's pushing. There's been plenty of revisions to electrical panels. Frequently scratch out what it was before and write on what it is now. So we're going through pulling those out, we're verifying, confirming the circuits are labeled appropriately. Typing the labeling in, so it's not just pencil written, getting it back. And unfortunately, was the bottom of our priority list for the year, so we will continue that. We finished a few, but not enough. There are hundreds of these. And things that went well, pictures below. Yeah, nice. So picture on the left is what the storeroom used to look like. Picture on the right is what our parts look like today. Yeah. Right, and then we did acquire some new storage space. Those are the middle pictures, and it's a disaster because they're working through how to organize that. And the next pictures are examples of, on the left, what a breaker panel might look like in the facility, and on the right, what it would look like when we're finished. Okay, things accomplished. Exterior campus lighting. It's been a lot better on campus with the new parking lot lights. And we've updated a lot of the halogen lights up to LED, and are just about almost 100% on campus for LED lights. Upgrade and migration to help desk ticket systems. That's so IS is part of utility systems as well. So they upgraded their work orders. It's taken a little bit of getting used to, but it's nice. That's it for utilities management. Any questions? Okay. Next one, medical equipment.
On this time.
Okay, medical equipment is the next one. No proposed change for 2024 as well. Performance measures for 23 were a new system supposed to capture all new equipment at time of implementation. What this really boils down to is a full-on asset management program. And it's really larger than this group. However, I want to keep it in here because we can see that it's part of 24 as well. It's one place and one group that can work with little pieces of it and getting to it. The concept behind that is, of course, not to prevent having pieces of equipment such as that is no longer supported by the manufacturer. So we have sunset dates for them, so we can get a plan for replacement. The next one is materials management to develop a process for surplus medical equipment. Previously, years past, we would retire a piece of medical equipment and try 7 or 8 different ways to get rid of it, and then it would end up being somewhere in the facility. And sure enough, Joint Commission, the first piece of equipment they would find was that one. Right? So we developed a process to where we get pieces of equipment out of here. We tracked that over this last year, 100%. Left within 3 months. So that was a success. And then organize and complete TMS PM updates by the end of 24. That one got about 20% of the way through, and that's what that is we have generic preventive maintenance processes for medical pieces of medical equipment, and we're trying to make them very manufacturer specific. Instead of check A, B, C, and D, the manufacturer might have an F and G, and make sure we're lined up with manufacturer's recommendations. So going through hundreds and hundreds of pieces. Okay, and performance improvement measures for 24. There they are. I go through them in detail. Accomplishments, we actually put smart televisions throughout the hospital. Anticipation for the future. We have very adequate television system, and who doesn't want to be able to watch their Netflix, whether it's anything currently. So, and then replaced all the IV pump batteries. That doesn't seem like a big thing, but it was, in fact that we had to scour the entire country, going to different vendors to try and find enough batteries to do it. Because we couldn't get it. So we did it, we got them changed out. So it's a success. Questions on that one? Okay, hazardous materials and waste. No proposed changes for 2024. Performance improvement measures, a little different for the hazardous materials and waste committee. They actually use Reliast and have developed questions that are testing staff knowledge. And so these are the goals that they set. Further, here they are, and the results. They'll use those results to drive performance improvement initiatives. There's a big block of red down at the bottom, as an example for disposable pharmaceuticals. That the three from the bottom that you just so they're in red. They're working with staff and working with the pharmacy to develop processes that the staff will adhere to improve. So they use this information to drive performance improvement and set goals for the upcoming year, which are below that. There they are listed. We had a few accomplishments for the year where they updated the hazardous materials reliance trains. They made it more user friendly, and there's some questions that were really hard to decipher what the right answer should be. So updated. And then through education, we've managed to maintain our volumes as a small quantity generator for hazardous waste. Although that's in question right now. We don't want to go into that here, but essentially being a small quantity generator gets us around a lot of manifesting licensing requirements. And taking that's really a small program, a small piece of it up to a big government. That's all I have for hazardous materials and waste. And
Jeanette's been very patient.
Okay, so I'm Jeanette Lacy, I'm the Director of Case Management. And the utilization management plan falls under my department. And this plan is required by CMS. The plan follows pretty much point by point the requirements of what is to be included in the plan. And basically it outlines how we'll work with the med staff for utilization and discharge planning. It also outlines our physician committee and the responsibilities of that committee. And so that's kind of the main point of the plan, but we made very few changes. This plan has been updated to reflect in the past the tools that we're using and to include CDI, which had not originally been in here. One of the primary changes we added under secondary review, go back to the top. Secondary review, we have a contracted service with sound physicians that we can work with for secondary review. They are on a referral, so charged by referral, so it's a service is only if we ask them to look at something. And then we added in here sound or hospital employee or contracted physician, so that just made it more broad of who can be our secondary physician reviewer. And then added a little bit of language on page 3. Just clarifying that, so the HIN and the ABN are notices, Medicare letters that patients are given if Medicare is no longer gonna cover their continued stay. And so we just clarify that we don't just have them sign it, we actually explain it to them and then have them sign it. And then otherwise I updated our references for the accurate dates. But I'm happy to go over the plan in more detail or the purpose of it, or I think the big thing, the physician, what we are looking at quarterly is at our physician committee. So what we're really watching and reporting on, which is in the committee minutes. We're looking at our denials management, we're looking at outliers, we're looking at CMS requirements for one-day stays. Under the 2 midnight rule, we're looking at observation lengths of stay. So all of those things are in our, we have dashboards that have all of that information. We have some specific goals that we're working on for this year that are not in our plan, they're not outlined in this plan, but specific toward utilization. This year, the state of Alaska moved to APR DRGs for Medicaid reimbursement, so we have goal about creating our new processes related to that and auditing and monitoring the outcomes of that. And making sure that things are as on the up and up as possible. We're gonna be watching our CMI for Medicaid and making sure that we're doing everything that we can to get our coding, our documentation and coding as accurate as possible. To make sure the goal is to not lose money, so we'll have to see how all this goes with the state. We have for our CDI goal, we looked at our highest rate of concurrent queries and decided that we're gonna have some focused education that's on nutrition, or rather malnutrition, not being documented accurately enough, so that the physicians have been getting the most queries on that one diagnosis. So we're gonna be looking at providing some education on that, trying to get that improved. Looking at our outliers, so there's lots of causes for outlier status, and a lot of that has to do with placement. When we have a patient who could go to outlier court or Sitka or some other facility for step down level of care, got really bad during COVID times because nobody was taking step down patients, and it's better now, but placements are still challenging, and a lot of times, patients don't want to go out of town or they're unable to go out of town. But those are not the only reasons for outlier status. I mean, outlier status, we have to look at our documentation and coding because, is there an opportunity for improved documentation and coding that would give them a longer expected length of stay, which would pull them out of outlier status? Is there something case management could have done different with discharge planning? Could they have had a payer conference sooner? So every outlier we're looking at to identify what those issues are and how we could do that better. Do we have providers who aren't participating with rounds? We have daily rounds, and we have all of therapies and nursing and case management, and it's really important for physicians to attend those rounds and be part of the treatment team, have treatment team meetings with patients and families. But if we have providers who are not doing that, impacts what the rest of us are able to do to help move that patient to the next level of care. So we're looking at all these different components of outlier status. And that's one of the things we're going to be really monitoring a little more. It's monitored every quarter, but also now, looking at how can we reduce these outliers that we do have. And then denials management, so streamlining our processes with patient financial services is another goal that we're working on. And then this year, we are now required to do our reporting to CMS on our health-related social needs, and we're closely with Kelsh on that. So we'll have a goal, our goal right now, so the requirement is on reporting. They don't have a benchmark for the number of patients that we screen for their social determinants or health-related social needs. But we have decided on an initial goal of 75% of all inpatients that are 18 and older. Hopefully we can surpass that, but we wanted it to, getting 100% is a little bit hard, especially if you have short stays. There's lots of different reasons why it can be difficult to get 100% on that, but we're hoping to surpass 75% and, see where we go. And then if we can't, see what those barriers are, so we can make sure that we're getting all of those patients screened. So that's kind of the goals that we're working on. What questions does anybody have about the utilization management?
On your contracted secondary review, what percent of patients is that? Do you have an estimated percent of how often that occurs?
Oh, it's not very many, so like 10 cases a month.
10 cases out of how many?
Oh, let's see, how many patients do we have per month of the total number?
Just an estimate.
I'm just trying to add up, because I sort of out between Medicare and Medicaid and private insurers. I don't know if we have 60 something per month. Do you know off the top of your head? Do you know? Inpatients, have to double check.
Okay.
But it's not, it's not a ton, but it is good for us to have that review because the utilization is their nurses. And so if they have a concern about whether the patient meets inpatient status or, really should be observation status, it goes both ways. So if the physician is writing an inpatient order and we're like, oh, that is not meeting criteria, and they're, they can explain that to the provider, but we want to make sure, or on the other hand, when we have a patient who comes in under observation status and it's really iffy whether or not they should meet for inpatient or not, it's a big deal because, especially with our Medicare patients, because once they have an inpatient order, it sounds kind of bad, but you have to have a safe discharge plan for them. You have to have all of these certain things. An observation patient is an outpatient status. A lot of times there can be some iffy things between, is this really a custodial patient? Do they really need an assisted living? Or is there an acute issue going on and they need inpatient level of care, and then we need to get them to a step down level of care or whatnot? And the reason that really matters is because they have to meet that inpatient level of care to qualify to go to that step down level of care. So we want to be really careful and make sure that on those ones that are iffy, they're not black and white, that we get that secondary review to make sure that we're not advising that physician in the wrong direction.
Okay, thank you. And my famous last question is, do you have the resources and tools that you need?
I think we do, yes.
Thank you. Thank you for all you do.
Thank you.
All right, thank you, Jeanette. So we do need an action item coming out of this committee to recommend to the board, so, Lisa or Shelley, you want to make the motion? Got it up here.
Okay, I move the Quality Committee of Bartlett Regional Hospital approve the Patient Safety and Quality Improvement Plan, Infection Improvement Plan, Case Management Plan, and Environment of Care Plan, and forward them to the full board of directors of the Bartlett Regional Hospital for approval.
Do you need a second for that?
We do. So Lisa seconds that. Right?
Yeah,
Thank you, so, that's great, we'll move this on to the board, for the next board meeting. Yeah, I believe we've come to the end of our agenda, so thank you guys very much for doing this. That was it.
Sometimes-
Thank you, everyone. It was great.
Thank you, Lisa.
Thanks.
Thank you.
I did not.
Oh, it's good.